And let me know when I have to stop. I have planned for 12, 13 minutes. So my idea is you have probably covered the most important surgical topics on the transpetrosal approaches. So my idea was just to share some anatomical concepts and how the understanding of this anatomy can help us to optimize our surgical approach with a final conclusion. So the Petrous bone is a very important part of the temporal bone, which is mainly divided in the squamous, tympanic, styloid, and Petrous part. So understanding the different junctions of these different compartments is very useful to plan craniotomies and to understand from which area we can enter the Petrous bone. If we have a top view of the skull base, we can see the central position, centrolateral position of the Petrous bone, which is joined anteriorly with the greater sphenoid wing and the squamous part of the temporal bone, and also posteriorly in the posterior fossa with all the components of the occipital bone. So you can see how in between these boundaries we have some sutures through which, and canals and holes through which important neurovascular structures are crossing. And one important anatomical landmark of the Petrous bone is the one located at the level of the Petrous ridge, which is finally dividing the middle from the posterior fossa with the attachment of the 10th and the superior petrosal sinus that will be covered later on. If we have now a caudal or inferior view, we can see important relationships of the Petrous bone, mainly with the carotid artery, jugular valve, and the jugular foramen, and the lower cranial nerves and the fascial nerve, which is going through the stylomastoid foramen in the basal part of the Petrous bone. It's important to know that the Petrous bone is not just a bone through which some of these structures are crossing, but for practical reasons, we divide it in anterior, middle, and posterior, and all these parts have intrinsic important structures, mainly neurovascular structures, and some structures related to the vestibulocochlear system, as we will see later on. Important is to know also, in order to plan surgical approaches, the relationship of this Petrous bone with the dural layers and some important venous sinuses. As we can see in this superior view in the left side, we can see the close relationship of the Petrous bone with the superior petrosal, inferior petrosal sinus, and how they are joined at the level of the jugular valve and junction of the transverse sigmoid sinus. So this triangle in the posterior fossa in between the superior, inferior petrosal sinuses and the sigmoid sinus is what we call the petrosal surface of the petrosal bone in the posterior fossa, which is traversed by important neurovascular structures, as we will see later on. Important also to realize that when we want to do a middle fossa approach, as we have discussed with previous speakers, we have to understand the different dural layers. So we have the periosteal dura and the dura propria. Very important to know this concept, because as you can see in this anatomical dissection, we have this ESPN, which is leaving the fascial nerve and running anteromedially towards the Gasserian ganglion and the V3 mainly. How important it is to know all these intrinsic structures, mainly important to correlate these anatomical structures with our CT scans and the MRIs. So here we can see how the anterior, middle, and posterior parts of the Petrous bone are completely filled by important neurovascular structures and by structures which are composing the vestibulocochlear system. So we have the external auditory meatus, the internal auditory meatus, and in between them, which is followed by this transverse vector, we have the middle ear with the important auricular ossicles. So we can see how in the anterior Petrous bone, we have mainly the cochlea, which is divided in this rhomboid or triangular fossa, depending on who is speaking about it. But the limits, the important thing is that the limits are given by the superior petrosal sinus in the most anterior part, V3 and Gasserian ganglion in the medial aspect. Anteriorly, we have the GSPN, and laterally, we have the internal acoustic meatus. And the cochlea is located in the most posterolateral part of this rhomboid or triangular shaped structure of the Petrous bone. In the posterior part of the Petrous bone, we mainly have the mastoid ear cells, which give us access to the mastoid antrum and finally to the middle ear. And in between them, we have this line crossing with the location of the internal acoustic meatus, in which inner part we will encounter the vestibular, cochlear, and fascial nerves. So coming again to the radiological anatomical correlation, we can see how the jugular valve can be identified from interiorly and posteriorly. So we can see how the sigmoid sinus is running downwards and medially just to reach the jugular foramen, which is divided, as we will see later on, in two parts by the jugular process of the jugular foramen, dividing the pars nervosa and pars vascularis, and how important it is to be aware of the relative location of the Petrous internal carotid artery to plan our approaches. Important things about the veins, especially when we are planning to do a classic retrosigmoid approach, is to understand how the mastoid emissary vein, which is connecting the sigmoid sinus with the extracranial structures, is not running directly perpendicular to the cortical part of the skull base bone, but is running in this antero-medial direction. So it's important to know this, because once we identify this mastoid emissary vein in the surface of the skull base, we can guess that our sigmoid sinus, which will be a bit more anterior, so we have space enough for our craniotomy or for our drilling. Some anatomical variants, as you can see in this left side image in the CT scan, you can see how this sigmoid sinus can be engulfed. And this is very important for surgical purposes, because sometimes in cases like this, we cannot completely get free the sigmoid sinus. So the mobilization of itself will be difficult if we don't release the pressure of the bone around it. So what we did in this case was just to leave this bone ring at the level of the sigmoid sinus in order to avoid creating any venous problem. So important not only get stuck on the anatomical classic findings, but study carefully the individual anatomy through the MRI and the CT scans. So important variations, as I just have mentioned, we can have a high jugular valve. This tumor was done by an ENT colleague, very experienced, but he didn't probably realize how high the jugular valve was located. So this translabyrinthine approach became a mess till he was able to control the bleeding. And we must be aware of the different high jugular valve variations. So in this case, drilling the lateral wall of the internal acoustic meatus is a risky maneuver, because we will have there directly our high jugular valve. So it gave me a nice chance to remove it through the retrosigmoid approach. Going inside the intradural space and going to the Petrous apex, we can find some small Petrous apex meningiomas like this one, which are compressing posteriorly or laterally our trigeminal nerve. So it's important to analyze not only these T2 volumetric studies where we can see the trigeminal nerve pushed posteriorly, but also the CT scan, because in this case we have a quite prominent suprameatal tubercle. So in this case, we will probably need to drill this part of the middle aspect of the Petrous bone in order to reach the entry to the Meckel's cave and release the pressure of the trigeminal nerve. So this is what we were doing here. We are releasing the arachnoid membranes, creating as much space as possible through the retrosigmoid. And you can see how this huge suprameatal tubercle needed to be drilled in order to release the pressure of the trigeminal nerve, which is severely compressed by the tumor. So this was the first maneuver that we had already planned beforehand. Again, important to study that in the CT scan, we can find some pneumatization, partial pneumatization of this structure. So important to place some bone wax. And now we can mobilize the trigeminal nerve and work superiorly and inferiorly on these windows and finally coagulate that. So you can see how we have filled this with some bone wax, and we have the remnant tumor here. The sixth nerve is here, so that's why the endoscope was useful to realize that we could even completely coagulate that area there. So going to another case, and some tumors, benign tumors, luckily they create space for us and they do the petrosectomy for us. And this is very common in trigeminal schwannomas, but also in some tumors like this, which is, to my understanding, a fascial schwannoma. The patient came with fascial palsy grade 5 at this stage of the evolution of this tumor. So you can see how this tumor is following indeed the trajectory of 4 of the segments indeed of the fascial nerve, cisternal, intrameatal, tympanic, and also the labyrinthine segment. So you can see and you can follow the anatomy of this tumor and understand how it's a fascial nerve schwannoma. So important to try to identify in this normal CT scan where the different components of the fascial nerve are located. So we have the 6 components of the fascial nerve, and this tumor is following 4 of these cisternal meatal labyrinthine tympanic mastoid and styloid segment of the facial nerve. So in this case, what we want to do is to follow the anatomy of the tumor, so trying to find this subtemporal exposure with which we will be able to extradurally, first of all, follow the main axis and to align the surgical trajectory with the main axis of the tumor. So we start with the middle fossa resection. We are trying to do this interdural peeling. This is the Petrous bone carotid artery, which was just underlying below the tumor, so important to identify it. So now we are moving more posteriorly to the roof of the internal acoustic meatus, which was partially broken by the tumor. This is the 10th, so we have access to the posterior fossa, to the infratentorial space and to the supratentorial space. This patient had trigeminal neuralgia, so we did an exposure of the trigeminal nerve. So now we are coagulating and ligating the superior petrosal sinus for our petrosal opening, and to realize that this trigeminal nerve was pushed superiorly by the tumor and compressed ventrally by the superior cerebellar artery. So we wanted to release the pressure also of that. And this is the last part of the tumor, which is located in the cisternal component. This is the cisternal part of this facial nerve schwannoma, which I was not able to remove completely because it was too low. So even drilling the Petrous bone, I was not able to take the last part of it with in a safe way. So this is why I left a small remnant in the posterior fossa, as you can see. And sometimes the tumors, despite the fact that they are very small, they can create a grade 5 facial palsy, like this small cholesteatoma. Why? Because this tumor is mainly growing and irritating this important part of the facial nerve, which is located just at the level of the cochlea. So in this case, we really need it to be accurate on the exposure. So this is a subtemporal approach. We are drilling the lower part of the squamous part of the temporal bone in order to access the middle fossa floor, and we want to start our middle fossa peeling at the level of the foramen spinosum. So we identify where the middle meningeal artery is. We try to coagulate it, cut it, and start our drilling here. So I'm cutting it. It was not properly coagulated, so we can work with the bipolar or even with some bone wax. And now the important thing starts, because we want to identify ESPN. So I went to the foramen ovale and V3 from there posteriorly all the way lateral. So this is the ESPN. I checked it with the monopolar probe till I got response on the facial nerve. So this is the location of the cochlea where the tumor was growing and compressing that geniculate ganglion on that area. So that's another way in which the anatomical understanding and planning can help us to optimize the resection of a tumor like that. Going to the central compartment of the Petrous bone, we have the internal acoustic meatus here, where we have important nerves, as we said before, superior, inferior vestibular nerves, cochlear nerve, and facial nerve, which are anterior, located in this area. And here we have usually a small intracanalicular schwannomas, which we usually don't operate, but this case was very special. It was a young kid, 11 years old. He was deaf on the left side since he was a baby, so he started having some hearing problems in the right side with this schwannoma, which grew in 18 months. So we decided to do a retrosigmoid approach with the drilling of this lateral wall of the internal acoustic meatus, taking into consideration the location of the labyrinth we didn't want to damage. So this was the space that we could reach. And this is the retrosigmoid exposure. So as you will see, after releasing CSF from the cerebellomedullary system, we identify the superior and inferior vestibular nerves, so we can see how the tumor is coming out from the intrameatal or the meatal component. So this is the nerve, superior and inferior vestibular nerves. And this is how the tumor is mainly located in interacoustic meatus. With this maneuver, luckily the patient recovered a little bit the hearing function, which went to the normal basis after the resection, but at least we could keep the hearing function as it was before surgery. And this is the most difficult part, the most anteriorly located part of this tumor, which is the fundus of the internal acoustic meatus. So we were able to take it out with this 30 degrees endoscope looking up into the internal acoustic meatus. So this is how the understanding of the Petrous bone can help us to have a good clinical result. Finally, I have a couple of cholesteatomas, which are typical lesions located in the Petrous bone. So this one is located, as you can see, at the level of the sigmoid junction with the jugular valve at the lateral aspect of the jugular foramen. So it's important to monitor the facial nerve, the mastoid segment of the facial nerve, which is located just 18 millimeters deep at the level of the spine of Henle. This patient was operated many years before, so that's why she had some scar tissue located in the external auditory meatus, which I'm drilling right now. So this is the mastoidectomy with our triangle, and we are approaching the relative location of the mastoid segment of the facial nerve. So we are checking that with a monopolar probe, and as we are going deep and deep, we will be more aware about the location of the lower cranial nerves in the lateral aspect of the jugular valve. So with these dissectors, angle dissectors, which are connected to the neuromonitoring system, we can dissect, remove tumor, and at the same time identify the location of the mastoid segment of the facial nerve, which we can see nicely in this anatomical dissection. Finally, this is what we have been mentioning. We have a posterior part, which is mainly related with the mastoidectomy and posterior petrosectomy, mainly filled by antroid cells and the mastoid antrum, which is giving us access to the middle ear and the labyrinth, internal acoustic meatus and cochlea. And finally, in the most anterior part, what we call the Petrous apex, we have important aspects of the carotid. We have the Petrous segment and a serum segment of the internal carotid artery, and also the Meckel's cave with the fifth nerve, as we already discussed. So it's important to know all this anatomy, in my short experience, to try to avoid to do complex transpetrosal approaches and to find a safer way, which mainly subtemporal or retrosigmoid approach. So we have to do this work in the lab. So this is a combined transpetrosal approach in which we are combining a retrosigmoid, presigmoid, and subtemporal exposure, as James Liu has excellently showed us before. So we can have access to the presigmoid dura to have a more ventral view of the anterolateral aspect of the pons, as we already saw before. So we can do this retrolabyrinthine, translabyrinthine approach, which is enhancing and increasing our surgical view of this area. As you can see here, from the fourth to the lower cranial nerves, we can deal with chordomas like this one, doing this combined transpetrosal, which will give us a good chance, in this case mainly, to identify some basilar perforators. After the compression, you can see how the basilar perforators, some of them are somehow quite attached to the capsule of a tumor like this. So that was, I was scared of doing an endonasal endoscopic approach in this case. So this is the clivus, and this is the contralateral third nerve. So we have seen translabyrinthine approach, and if we complete this dissection in the lab, we can do a transotic, a transcochlear approach to expose a benign tumor, which in my mind has nonsense. So this is a typical exercise that it's perfect in the lab, but mainly in my practice, I try just to deal with tumors which are doing these petrosectomies for us. Otherwise, I try to look for a safer route with which I feel more comfortable, and I believe it's safer for the patient. But as you can see, some tumors like this cholesteatoma, which was operated 25 years back, we can have this total petrosectomy by the tumor itself. So we just open the gate, expose the mastoid, identify our external anatomical landmarks, posterior to the root of the zygoma, the asterion spine of Henle. So we have access to the external auditory meatus, which is skeletonized. And now we go deep and deep, just enter the tumor and just follow its anatomy. In this case, we can do a very aggressive resection if needed. This patient was 68 years old, so we just wanted to remove as much tumor as possible and to try to preserve the facial nerve function. So that's why I was working with the navigation. In a case like this, I really like using the navigation to know how deep I'm getting, to know how close I'm getting to the nerve, facial nerve that I have planned before to work in between anteriorly and posteriorly. So this is the posterior window. This is the sigmoid sinus, that's the jugular valve. So we can see it externally. Now we are going up to the labyrinth. So this is the inferior aspect of the labyrinth. We are trying to work in this infralabyrinthine window, and with this small match head diamond drill, we can expose a bit more the presigmoid dura in order to have more access. And some important things about this tumor is that it probably ruptured the dura and entered the posterior fossa exactly at that level. So that's why I was very careful at that area. But even that, I had a renal leak urea, which was finally requiring a reduced surgery in order to identify the point in which it was leaking. So that's the post-op after the first surgery. And just to conclude, I want to conclude saying that after doing many dissections in the lab and having some short experiences, surgical experiences, I try to avoid going through the Petrous bone, and I only do it in those cases in which I don't really feel that the retrosigmoid or supracerebellar, transtentorial or infratentorial can give me a good chance to remove the tumor in a safe way. So concluding, the Petrous bone is a very complex but really fascinating area of the skull base. It's a keystone structure which give us access to different fossa of the skull base, and it's filled by very important neurovascular structures that we have to be aware of. It's facing the middle infratemporal, jugular, and posterior fossa, so it's very important to know its anatomy and relationships, and a deep understanding of its anatomy is mandatory in order to deal with tumors in these areas, and it might be used as a corridor to reach these deep areas of the skull base, or even just to get in and deal with tumors which are intrapetrous. And nowadays we are not only doing our dissections in the lab, but also taking advantage of these nice toys. So we are planning to do segmentations of different intrinsic areas of the Petrous bone, so we can work with the anatomy of our patients, or safe patients, or patients with no pathology. So in order to identify all these structures, anterior, middle part of the posterior part of the Petrous bone, how its intrinsic anatomy is filled by the important structures, so we can identify the mastoid ear cells, the antrum, the access to the middle ear, presigmoid approaches, compare it with the presigmoid and retrosigmoid, which is the best angle to attack a single pathology. So we are now implementing this technology in our armamentarium in order to understand the anatomy and to plan our surgical cases. So that's all. Thank you for your attention. I hope I was not too tough, and thank you to Samek for his kind invitation, and congratulations for this fantastic success.
Okay, very good. Thank you, Pablo. And it looks like Sam has returned.
Thanks a lot. Yes, I'm here.
Yeah, Sam,
Thanks a lot.
Sam, you know, I think
my dear friend Gonzalez. Yes, I'm here.
Yeah, I
Thank you.
I think I'm overpaying you, Sam. Okay, go ahead.
Okay. Is there any question from panelists?
Yes, Sam, how are you?
Okay, I'm
Sam,
fine. Go ahead, say.
It was a fantastic presentation, and you have over the last several years, you have said how anatomy is important for neurosurgery, how good understanding of anatomy can improve your surgery. You have said about interaxial brain tumors, and now I have heard about Petrous bone tumors, and I am extremely happy with what you are doing. Now, the issue which I want to talk to you is about, as you also rightly said, that over the years, you will reduce your Petrous bone dissection and resection. As you grow in your experience in removing tumors, you will reduce your extent of Petrous bone resection. This is for sure. As regards facial nerve neurinomas, you showed 2 cases. I wish that you read my article on this subject, where I said that facial nerve neurinomas arise in the region of geniculate ganglia. And when they grow in the middle fossa and in the posterior fossa, they have a dural cover around the whole entire tumor. And if you preserve that dura, if you don't violate that dura and work within the dura, there is a good chance of radical resection and to save the part of the facial nerve if possible. Of course, it is not possible in grade 5 facial nerve palsy, but that is the only way, by avoiding the dural resection. The other thing is, if you avoid the dural resection, you can minimize your petrosectomy, you can minimize, like you expose the carotid artery and all those things. That can be avoided if you preserve and work within the dural confines, both in the middle fossa and in the posterior fossa. So that is about the facial nerve, I wanted to say. Other thing I wanted to say about the cholesteatoma. You see, the cholesteatomas, as you said about the CSF leakage and all those things, you see, cholesteatomas, my feeling is that you have to block the eustachian tube. And if you have worked inside the dura, you can have definite CSF rhinorrhea or otorrhea if you have not blocked the eustachian tube after you have done your cholesteatoma resection. So let me know what your comments are on these issues.
Thank you. So the thing is that with that fascial nerve, I fully agree with you. And I realized that in the lab previously, but also during this surgery. But specifically in this case, I really wanted to see the trigeminal nerve, because the reason why the patient complained was because of the trigeminal neuralgia. So I really wanted to have a look intradurally at the trigeminal nerve entry zone. So that's why I had to, let's say, somehow open the dura. But I read your paper, you already told me, so I know about that. And about the cholesteatomas, also you already told me in Mumbai a couple of years back, 1 year back, and that's something I really learned with this case. So yes, I have to block. We have to try to block the Eustachian tube if it's accessible to our view, so that will reduce the chances of having rhinorrhea. Thank you.
Thank you, Pablo. Best wishes to you, dear Pablo.
Thank you, Professor.